Good afternoon, everybody. I hope you're doing well in this beautiful day. My name is Liliana Burbano, and I welcome you to the last session of the Health Equity and Research Series, HERES. We are going to also close our National Minority Health Month with this session, and I hope you find it useful and informative for your practice. So I will go ahead and get started. My name is Liliana Burbano. I'm the Community Health Equity Director for UT Medical Center. I'm originally from Colombia. I use she, hers pronouns, and I'm originally a public health practitioner. So you will have kind of like some part of that perspective in my presentation today. Okay. Perfect. So as I mentioned, this presentation is part of our observance of the National Minority Health Month, which concludes next week. And I invite you to read some of the blogs that have been posted, which I found very interested in terms of understanding the challenges that minority groups face when accessing the healthcare system. I would like to start my presentation with two main principles. And the first one is about health. And let's understand that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And sometimes it's hard to understand this concept when we work in a medical center, when we see patients that are sick, but having that previous understanding that health is beyond being sick is extremely important. The other principle that I want you to keep in mind is the fact that there are so many factors that affect health, including physical environment, health behaviors, and socioeconomic factors, which we will touch in some of those, but we will primarily center on the access to healthcare and the healthcare factors that affect the health outcomes of our patients. So it is important that we center also our attention that when we talk about healthcare factors, we are referring to access to healthcare, but also the quality of the healthcare that we provide. So those are the objectives for this presentation today. The first one is to increase your knowledge of the Hispanic Latino communities and their barriers to access the healthcare system. Second, we will learn how cultural values and beliefs affect health outcomes. And finally, we'll provide recommendations on how to best connect with minority populations, particularly members of the Hispanic Latino community. So let's start by saying that Hispanics, Latinos, or Latin Americans are 18% of the US population. So it is not a small group of people. It might look smaller in our area, but it is not a small group, and is actually the fastest growing minority population in the US. So now I would like to share information about our service area. So for those of you working with UT Medical Center, you know that we serve a 21 county service area. And although some of the areas might seem very, very small, I want you to refer your attention to counties such as Hamblin with a 12% of Hispanic population, followed by Loudoun with 9%, Sevier with 7%, and Knox County with 5%. So those are populations that might be undercounted, and this population is fastly growing. But also I want you to compare that data with this data that actually has been included in our D&I report for 2023. And as you can see here, this reflects the population in Knox County and the surrounding areas. But unfortunately, our population for Latino Hispanic patients is just 2%, and only 1.8% represents Hispanics in our UT Medical Center team members. So now we're going to start talking about the Hispanics, Latinos, Latin Americans, and what is specific about them, and some of the elements that I think that you might find interesting in this process. So let's start saying that Latin America is a geographic concept. And in many cases, it also includes a cultural element, right? And depending on the definition that you use, it might include from 23 to 25 countries. But here you have the main list of countries that we commonly refer to as Latin American countries. And those are from North America, including Mexico, all the way to the Caribbean, including in Central America, Belize, Costa Rica, El Salvador, Guatemala, Honduras, Nicaragua, and in South America, Argentina, Bolivia, Brazil, Chile, Colombia, Ecuador, French Guyana, Guyana, Paraguay, Peru, Suriname, Uruguay, and Venezuela. And in the Caribbean, we find Cuba, Dominican Republic, Haiti, and Puerto Rico. And we find others that, based on some definitions, might be included or may not. Usually they are excluded from a definition as Latin American countries. So now the other concept that you see quite often is Hispanic. And Hispanic refers primarily to language, right? It refers to those who speak Spanish. So why is it important to know? Is because basically, if we look at the Latin American countries, it will exclude probably the largest country in Latin America, which is Brazil, and Haiti. But it will include Spain, right? Which is in Europe. So it is very important that you say that not all Hispanics are Latinos and not all Latinos are Hispanics. The other element that I want to highlight here is that although somebody might look like Hispanic, they may be Mayan descent, and those are indigenous cultures in Central America. You might see a lot of our patients for labor and delivery that look like the woman that I'm including here, and she might be Guatemalan. The difference is, and although Guatemala is a country in Latin America, and their official language, I believe, is officially Spanish, many of the members of this community will not speak Spanish. So calling a Spanish interpreter will be kind of like useless for this process. What is important to know is that I speak dialects, Mayan dialects, that include Mam, Canjobal, Yacateco. Unfortunately, I was recently informed that our language services do not include these languages any longer. But it is important to note that for many of these men and women coming to our healthcare system, Spanish might be their second language. So even using a Spanish interpreter or the language line might be challenging while working with these patients. Additional information that I wanted to provide is that most, if not, I will say 90% of the Mayan patients or Guatemalan patients that come from these areas come from areas in Guatemala such as Quetzaltenango, San Marcos, and Huehuetenango. So now this is one of the big questions that I usually get, right? What should I use? Should I refer to them as Hispanic? Should I refer as Latino, Latina, Latine, Latinx? And I'm going to go in each one of them. So if the patient speaks Spanish, you can refer to them and you ask them as Hispanic, right? So now the question is Latino, Latina. And this is very important that for many of you that might already know about Spanish, Spanish is a gendered language, right? So almost everything, I will say, even things, you know, a computer, a table, a house, a car will have a gender, right? And it is hard to understand, and maybe sometimes this is the hardest part for non-English speaking learners to understand that everything has a gender. So you refer as a Latino to a man, you refer as a Latina as a female patient, right? Now we are moving in a different direction. The whole world is moving to a different direction and is using inclusive pronouns, right? But it is very challenging for a language such as Spanish to change the entire language because it's already gendered. So what you will find is that some countries, particularly Latin American countries, are using or opting to change the O or the A for an E. So you will find that the concept Latine is recently quite used in some of the Latin American countries. You have some countries that are very orthodox with the use of their Spanish and they don't want to move in either direction. And they keep using niños and niñas, Latinos y Latinas, even if it makes it more cumbersome. The last concept that you see here in the slide is Latinx. Latinx is a concept that is primarily used here in the US. It is highly utilized in the academic world. So you see that a lot of in academia and papers when they want to refer to the Latin American communities. It is highly used by millennials and younger populations, but it is not very well received by older populations or more traditional members of the Latin American community. So now you have kind of like a description of the concepts. Now you know how to use it. For instance, if you ask me, I am a Hispanic Latina, right? So now let's start with a little bit more of the conceptual part of this presentation. So let's start with health disparities. And this is the definition that we are using in the hospital. So the health disparities are plausible, avoidable, systemic health differences adversely affecting economically or social disadvantaged groups. So it is important to know that about 50% of Hispanics and Latinos die due to diabetes and liver disease, when compared to non-white Hispanics. Also, studies show that Hispanics are or were 50% less likely to go to mental health treatment. And that could be twofold, right? It could be because it's still a stigma in our culture, right? We don't talk about these things. We keep it secret. We keep it very, very close in our family structure, but also because there are not that many providers that know about the language and know about the culture. So it could be twofold. It could be because the way we approach mental health, many years ago, I remember saying, people saying, I'm not crazy. I don't need a psychologist. And we see a big change with younger generations, but maybe older populations don't feel comfortable with the reference of needing mental health help. And not surprisingly, Latinos and Hispanics experience higher risk for obesity, and that might be related to even the kinds of diets that we include as part of our culture. So now there is another concept, and that is healthcare disparities. And healthcare disparities refer specifically to differences in the way populations or population groups access and experience and receive healthcare. So that is speaking to us, right? Working in a healthcare system. So we know that many groups and minority groups and different populations experience barriers in different ways, right? And now we're going to start kind of like getting some of those experiences and barriers experienced by the Hispanic population. So let's start by saying that this data is very, it tells a story, right? Well, you have 9.4% of all Americans that are uninsured and 15.2% of African Americans, you have 27% of Hispanics who do not have access to healthcare, right? Are uninsured. So it tells you that almost a third of all Hispanics don't have access to healthcare insurance. And why is it important? We know that access to healthcare promotes and maintains health, prevents and manages disease, reduces unnecessary hospitalizations, disability, and premature death. But there are several barriers, right? We see that there are high costs of care. We see that there is inadequate insurance or no insurance. As we mentioned previously, there is data on the rates of uninsured patients, but also a phenomenon that we are finding recently, through which we are actually having community conversations, is that Latin American immigrants that are coming to this country are often offered insurance that actually don't cover that much, right? So when they go to a provider and they don't know what is in network, out of network, it's hard to understand a new system. It works completely different from the Latin American countries. So it is very challenging for many of them when they have inadequate insurance or no insurance, right? There are many areas that don't have access to services, healthcare services. And primarily, probably that might be one of the main barriers, is that the lack of care that meets patients' social, cultural, and linguistic needs. So this is very important. I'm going to read it to you. According to a Pew Research Center report, 44% say communication problems from language and cultural differences are major reason why Hispanic adults generally have poor health outcomes, right? And we should not assume that all Hispanics don't speak Spanish, but it's not just the language, but it's the communication itself. So something that it's a call to action is what can we improve in terms of communication when we are helping somebody from this community. And it is important to notice that access to healthcare doesn't happen at the doctor's office, right? It happens with somebody calls to make an appointment, with somebody shows up at our practice. So all those could be barriers that they find, and we can proactively address those in our own practices. Language barriers often inhibit or reduce quality of care that Hispanic, Latinos, or Latinas, as well as other non-English proficient persons receive. Even when it comes simply scheduling an appointment to see a provider, one study found that 29% of Spanish-speaking patients have difficulty as a result of languages. So I want you to be aware that this is very challenging. This is an issue, and fortunately, the hospital is moving towards addressing those issues in our healthcare system. But still, we will continue to face many challenges related to language. Now we are going to move towards culture, values, and beliefs. And one thing that is extremely important is quite often Latinos or Latin Americans are put in the same bag, right? Everybody from Mexico to Argentina, including the Caribbean islands, are put in the same bag. And we think that all of them are the same. And it is important that we recognize that Latin Americans are extremely diverse. Even within their own countries, there is a massive amount of diversity. And culturally diversity as well. It is important to recognize that national values and history are fundamental to their identity. So somebody who is from Mexico is very different from somebody who is from Argentina and have gone through very different processes and historical events that have affected them, right? The other concept that I want to mention is race and ethnicity. And sometimes within our healthcare system, we find some frustration, and we face this frustration when we ask our patients about their race or ethnicity, right? And actually, we tend to see that they don't know. Probably they will ask the question, are you Hispanic or Latino? And they will tell you yes, right? But when it comes to the question of race, it is very complex, understanding that we only have, I believe, 5 to 6 options. And the only one that quite kind of like apply to a Hispanic or Latino person is the other category. So it is quite often that people will tell you that they are, when you ask about race, after asking if they identify as Hispanic or Latino, they will tell you, I am Mexican, I am Colombian, I am Guatemalan, or whatever country they come from. And it is very, very confusing for our healthcare system. But I want to encourage you to help us fill that information, because if we don't collect information on race or ethnicity, it's really hard for us to understand what are the healthcare disparities or the health disparities in outcomes for the different populations in the hospital. There are things that are very important to consider while working with Hispanic or Latinos. One thing is the degree of acculturation, right? It's very different to deal with somebody who immediately comes to the United States and includes and addresses and embraces the culture, as opposed to somebody who wants to keep their culture and their traditions. So it's different. That's very different. And you might find somebody who's very new to the States and immediately start the process of acculturation. Some others have been here for 20, 30 years, and they remain very, very loyal to their cultures and values. The second one is language, right? And it is very, very important that we understand that even within our country, sometimes it's hard for us as Latin Americans to understand each other because our languages vary geographically, right? Even within my own country, I find people who speak Spanish in my own country where we have words that have different meanings, and we refer to things in the same way that happens in the United States, right? You find difference with the East and West Coast and the Midwest and the South. So I want you to have that the same perspective, the same thing that happens in the United States, and that sometimes is different to understand the language that they're speaking. It happens in other countries as well. The next one is immigration and citizenship status, and there is extremely important, and I wanted to plug. So an educational opportunity, we will have a lawyer from UTK who will speak to us about the differences and the different options in terms of immigration and citizenship status. It is very important that we do not ask, if not necessary, the question about citizenship, because in reality, that doesn't tell us that much, right? We might have, and it is my case, I live in this country as a resident, as a green card holder for 15 years, but I was never a citizen until last year. And the differences were very, very minimal. The only difference is I didn't have the right to vote, but I have access to healthcare and I have access to other resources. So let's not assume that because somebody is not a citizen, this person is undocumented. I have seen cases in healthcare where we assume that somebody who looks Hispanic is immediately undocumented, and we think that they are not eligible for some resources. So sometimes it's very sensitive to ask those questions, and we should not ask them unless it's necessary, right? We are in a political climate where asking those questions, if it is not necessary, doesn't help create a culture or trust with our patients, and actually create some kind of separation. A socioeconomic status is fundamental, as we have seen it with other minority groups and other communities, even for our rural areas. Is very different a place or where you position yourself depending on the socioeconomic status that you have in society. Educational attainment is extremely important, and you may find even that some of the patients that you serve that come from rural areas or indigenous communities have never been in a school. They can barely write their name. They don't know how to read even their dialects or Spanish. So it is very important that when we do discharge planning, or when we send them recommendations or their care plan, that we address those issues. Because something that is not, it didn't include in this presentation, but we need to understand that in the Hispanic communities, we have figures of authority that we will never say no to, right? And those are probably the clergy, education, law enforcement, and healthcare. And you have found in your encounters with these patients that you are telling them things, and you are telling them what they need to do, or the medication or the next steps, and they will not all the time. But at the same time, you know that they are not understanding. So having this kind of conversation of reply back, repeat back, what do you understand about what I just said, is extremely important. And I just wanted to mention that the Preston Library, the Health Information Center, has wonderful resources that can help you include these communication skills to repeat back, right? To have that communication. It is very, very important that you create that bond and that relationship with these patients, and understand that culturally they might say yes to everything you say. They might not to every single suggestion, even if they disagree, because they don't want to show as disrespectful. They don't want to probably challenge your authority. The next one is foreign born, and it is very important to understand that you can have Hispanics or Latinos or Latin Americans that identified as such, that were foreign born, but some others that identified in the same way, that are US citizens born in the USA, right? So it makes a different way in which you experience your Latinidad, the way of being Latino. And it really shares a different perspective of being Latino if you're born in another country, if you're born here, right? And the last one is recent immigrants, right? And we know that immigration in this country changes almost every day. We receive community members from some countries, some others we don't receive, but we see that we receive a lot of refugees and asylum seekers. So those people might be fleeing conflict in their countries. So if you find people that are asylum seekers or asylees and refugees, they might have histories of violence and trauma that might affect their health outcomes. And it is important that you are knowledgeable about those, because it will affect the way that they relate to you, but also they will affect their health outcomes. Next, I'm going to share some information that you can find in the most recently published book from the Joint Commission, and it's toward healthcare equity. Hopefully, we will have this material available for all our team members. It's fantastic and includes information for all minority groups, religious groups, etc. So I hope this material will be available for all our team members. So I'm going to start presenting some information that I think you might find useful. I believe, if I'm not wrong, that our two interpreters, Luisa and Sebastian, are here, and I would like them to be able to interrupt and provide some examples that they have found while working at UT Medical Center as appropriate. And I will share some of this information. So let's just start by saying that personal relationships are extremely important for Latin Americans. So even creating that first approach, right? Not just for the physicians and the nurses, but from the front desk, right? When we call to make an appointment, that really makes a change in the way that we interact. So thinking about the importance of personal relationship for these patients might change the way that we interact with those patients. Secondly, you need to understand that family is extremely important. It's a fundamental pillar for the Hispanic Latino culture. And why is it important? Because you might have to face some challenges when you see large groups of people that want to come and visit somebody who is an inpatient in our hospital, or somebody who wants to come with a patient for their doctor's appointment, right? And sometimes we don't understand who's like, why is the mom or the mother-in-law of the sister or somebody else coming or is speaking for them? So it is very, very important that you understand kind of like the family roles that happen in some of these cultures. And as I mentioned before, it doesn't happen the same for every single culture and every single country. So you will have to learn how to read those signs that they provide. Also, within our families, we still have very traditional role models. And for families that are very traditional and very indigenous, probably they give a higher role to the males, who quite often make the decisions, are the decision makers for their family. And in many cases, they make decisions about health for their wives and their children. So this is an area that is important to know how to navigate. I clearly remember Luisa, that I hope that she's here, or Sebastian, when they ask, they say, and labor and delivery, they want to ask the patient if she's experiencing any pain, right? And the husband will say, no, she's not. But he will never ask his wife or his partner if she's experiencing any pain, right? So it is important to read those elements when you have an appointment or when you have an encounter with a patient. Also, expressiveness. We are very, very expressive, but also we differ in how we express privately and how we express publicly. And particularly for males, the expressiveness around pain it might differ, right? In the way that you experience your pain around people in your family and people that know you, and around your medical providers, right? You might be more stoic and probably don't want to show that you are having pain, but you are having a lot of pain, but you don't want to feel like your masculinity is is being questioned in this situation.
Liliana, we've got a hand up in the audience.
Okay.
Go ahead, Luisa.
Yeah.
Go ahead, Luisa.
Hello. Hi, everyone. My name is Luisa. I'm the coordinator of interpretive services here at the hospital. Thank you, Liliana, for the introduction. And this has been really great and really helpful, I think. Yeah, as you just said, specifically in some cultures, I would say Guatemala is one of those countries where the male is like, the head of the family. And because unfortunately, most of the women that we see in labor and delivery of those moms, they don't speak Spanish. The one who speaks Spanish at home is the man. So when we encounter those moments when we need to ask the mom, do you want this procedure, or are you willing to receive a blood transfusion, or are you in pain? The person who is helping us to cross this information is the man or the husband. And sometimes he will answer that question instead of telling the mom or telling the patient that if she wants that or if she's feeling that. So unfortunately, because this is the man and he thinks that he can answer, we just hear that. But as interpreters, we are there to encourage like the family member, in this case, the man, to please ask her or please do this. Because if we just keep going, we're never gonna know if the patient needs help. So it happens a lot, and we just try to help you, well, help the staff members understand these cultural nuances and how to address them. Thank you.
Thank you, Lisa. That was very, very useful. And also you need to understand that these families, the new families are mixed families, right? There are families that can bring their children from Guatemala, but they also have children here that are growing more with the culture of the United States. So those are families that sometimes struggle because some new members of their family, let's say the teenagers of the family, are shifting their values, the language that they use at home. So sometimes you see some conflict even within the families that are one unit and they are very different. So just to give you an example of these families that Luisa just mentioned, what happens in these families might be that you have the man who is the person who goes public and has a job and is the breadwinner for the family, while the mom stays at home with her children. Usually very limited to go somewhere because they don't have transportation, they don't drive, they don't have a job. So they are very isolated. They are, and because of the civil war in Guatemala, you will find that there is a lot of mistrust, right? Even they don't trust people from their own culture if they come from a different state or from a different area outside of their the state where they live. But also you will see that the kids who are brought up from Guatemala are completely different from the kids that are born and raised in the US. So the family dynamics are very, very interesting and very complex. So sometimes you might see some of this showing up in a doctor's appointment, right? If you have a teenager that comes with the mom and the dad, and they have a different perspective of what they want to see as an outcome of this appointment, and the mom has a different perspective and the dad is not communicating. So it is very, very challenging. As I mentioned before, we might be sometimes very private, and Guatemalans are very, very private about their emotions unless they really, really trust you, and it takes time to build that trust. Mental health is quite a lot a taboo topic, right? It is associated with the idea that you are crazy, that you are not right? But it's not completely accepted. I see that women that have been here, and there is a group of women with whom I'm working in the Lonsdale area who just recently are kind of like welcoming conversations around mental health, and they have seen the benefits, right? Their journeys from their countries are not easy, and the things that they have seen and lived during those journeys are terrifying, right? And they see that they need help processing that trauma. But also we need to have a health approach that is trauma-informed and trauma-based, right? Sometimes we don't know what they have been through, and the encounter might be also triggering. So also increasing your knowledge about trauma-informed approaches in healthcare might be extremely important while working with this community. And finally, in this slide, I suppose with everything that you might see in social media and in the news, Hispanic women are very modest, and particularly older and indigenous women and women from the Andes, maybe women that are not in the Caribbean, might be very, very modest. So keeping a patient covered, it is very important. Providing her with whatever resources she needs to be covered while she is in an appointment is extremely important. Okay, so now let's move towards another areas, and it is the emphasizing the understanding of the medical procedures. And this week or last week, I already lost track of the time. Sebastian, another one of our interpreters, mentioned a situation where sometimes we think that there is understanding and there is not an explanation about the procedure. And he clearly explained about circumcision, right? The provider was saying, this is something that we can offer to your kid. This is something that we offer to the newborn. And the concept that she had about the circumcision was different from her country. It was not what we were going to provide. So at some point, she was saying, yes, I'm willing. But finally, at some point, she understood that this was a medical procedure and she was completely opposed to that. So Luisa, I see that you have your hand raised.
I'm Sebastian, the medical interpreter.
Sebastian, sorry.
Yes, so I witnessed this case myself. She was explaining what the circumcision was, and she seemed to have understood what the nurse was talking about. And she kept saying, yes, yes. But we noticed that something was off, and then the nurse brought an image. And when she saw the little scissors going through the foreskin, she was like, oh no, like this is not what I was thinking. And what the patient had in her mind was her cultural practice of helping the baby boy when he's, I don't know, maybe 5 years old, helping the boy to get the foreskin fully retracted to the back. Like the mother or the dad typically helps the boy to do that. And she was thinking that the doctor or the hospital was offering that service of getting the baby boy's foreskin fully retracted. But once she saw the image and that this was a surgical thing, she said, no, I do not want that. That's not what I was meaning to say yes to. So that was interesting to catch and to correct in the moment.
Thank you, Sebastian. And really, it speaks to the need to speak the same language and make sure or ensure that there is understanding, right? I thought that it was very beautiful of you, Sebastian, saying, I missed this opportunity. I didn't realize that there were not communication. And Luisa, I would like if you can speak about the epidural, right? We assume that all moms, particularly from this community, know what an epidural is and what is the procedure, what needs to happen, and what you have encountered is quite the opposite, right?
Yeah, that's right. That is another thing that usually, healthcare providers are really used to ask immediately, do you want an epidural or this kind of like pain management? But for most of the moms in the Latin American community, and specifically moms from Guatemala or moms from that speak another language that is not Spanish, they don't understand this concept. And when we say, do you want an epidural? They might say no. Sometimes they say no, not because they don't want to, but because they don't know what it is. Or sometimes they will say yes, but they don't know what it is. And it's in that moment that as interpreters, we like kind of advocate and we say, okay, I feel like the patient, she's not understanding what it is. Do you mind to give more details about it? And when we explain the procedure, some of them, they will say, okay, no, this is not what I want, or okay, yes, please do that. But it is important to not like assume that everyone knows what is the procedure about. It's important to give more details because in our countries, not all moms are, they don't have this procedure available. Is really like in extreme cases or for a C-section, they're like, okay, I've been having 5 kids and we never had that before. So it's very like rare for them.
Thank you, Luisa. The next area that I wanted to address is the fact that there is a time present orientation for many members of this community, right? And sometimes because they live in survival mode, they are thinking about what needs to happen today, but this vision of the future and what things might affect you in the future might be not present. So sometimes it is hard to have these conversations about preventative care and preventative health and why is it important, right? The other concept is the medication adherence, right? And we see that quite often in the community is once the medication makes its purpose, right? The pain went away or the infection ended, and they finished the prescription, right? They decided to stop it. And it is extremely important that we make emphasis on the importance of the process, what could happen. We see that quite a lot, even with high blood pressure, diabetes, particularly with diseases that don't represent a physical symptom, right? You might have diabetes for many, many years and don't experience anything until you really need help. So understanding and having that conversation of why it's important to close this cycle, why is it important to find a primary care provider and have your regular visits with them is very important. Also, we need to understand that although we feel very proud about our diets and our access to fruits and vegetables, sometimes our diets are very heavy in salt and very heavy on fat and carbs. So nutritional counseling is very important for these communities. We have found that many women sometimes that they are in pregnancy develop gestational diabetes. Sometimes they don't know how to prepare their meals of why is this happening, and we say your sugars are high. No, this is what they will say, my sugars are high, and they cut any kind of candy or drinks, but didn't realize that probably the carb consumption is really high. So having those conversations, understanding what educational opportunities in Spanish are available and connecting them with those resources in the community is fundamental for them to achieve better health outcomes. Also, the perception about weight. And something that I found during my work with Guatemalan women in this community, and not just Guatemalan women, is that we believe that a chubby baby is a healthy baby, right? And sometimes that's not the case. But when we study the history of these countries of famine and starvation, they see a healthy baby as a chubby baby. It makes sense, right? And it is very important that we help them see weight and body image in a different perspective and more related to health. And finally, we know that because of the lack of access to medical providers, to the culturally and linguistic appropriate services, they are not accessing prenatal care or preventative care, so they rely heavily on the emergency department as their primary care provider. Also, it is important to know that in some situations, they see health conditions as natural, and that's the case of pregnancy. So pregnancy is a natural condition, so why do I need to have prenatal care? So when we understand and identify those situations, it is important to have a conversation of the importance of prenatal care throughout the entire pregnancy. Also understanding that some mothers of this part of this culture may prefer their mothers as their birthing partner. In some other cultures, they will prefer their mother-in-law, they will prefer the husband, they will prefer a doula. But the mothers are, in many, many cases, the preferred birthing partner. But also we need to understand that those families probably are the first generation here in the United States, and they might not have that opportunity to have their mothers being part of this process. So at some points, it appears kind of like a mourning experience for many of them and being by themselves. In many cases, the husbands are not the appropriate help that they would like to see. So they might be going through a process where they're mourning the lack of the women of their communities or their own mothers as part of the experience. We also found that they have an understanding of the body balance between hot and cold, right? And you might see it here, and I see it quite often, even during the summer when you see moms that deliver at the hospital and they live always with a hat on their heads and with a jacket. And it is because they understand that birth keeps out of the heat of the body, right? And they need to recover from that loss of heat. So even having that understanding of that cultural approach helps you know what to provide and what not to provide. So probably hot, cold drinks, ice drinks, chilling drinks will not be suitable for them, right? Also, they will have a different approach to bathing after giving birth or physical activity. Many of them have what we call a diet, the 40-day diet, where you stay in bed and you get served and you get helped. They might have a different preference of the kind of foods that they think that are healthy after birth, as well as the kind of drinks. So probably instead of having an iced tea, you can have a hot tea, right? So those are the kind of things that we might need to consider while they come here to the hospital. And there is a very interesting area that I found through the research that I was doing for this presentation is their view of colostrum. Many new mothers, even from our culture, which sometimes is very supportive of breastfeeding, believe that colostrum is spoiled milk, so they will not give it to their baby. So having that education in advance before they give birth, it is extremely important because we know of the importance of colostrum. Now let's talk about medication. So as I said before, we are a very complex and mixed group of people, and we might have very different perspectives about medication, right? So some people might lean towards a more natural approach. Some might be very supportive of this type of medication, but also you need to understand that some of them rely heavily on natural remedies that might interfere with the medications that you are prescribing. So having that conversation in a way that you acknowledge and recognize their approaches, but also have these conversations of how this might affect the prescription or the plan that you have for them is important to have. And there is a big culture on self-medication and self-treatment. One thing that you need to know is in many of the Hispanic stores in town and probably across the country, medications and medicine gets imported. So they can find different medications that they rely on back in their countries, and they buy it over the counter without a prescription. And those are things that can happen. So be aware that that's part of the daily life living in our area. Getting to the end of my presentation, I wanted to mention that in many countries, religion is very strong. It's a very strong core value, and that might affect even the way that we relate to any kind of medical procedures or perspectives about the end of life, right? Some religious approaches might see illness and death in a different way, depending on your religious beliefs. They might reject practices that they perceive like encouraging death. In some cases, when there is a bad prognosis for a patient, they might want to keep that information away from the patient, right? Because they want to protect the patient. They might resist hospice measures, and they might be very reluctant to removing life support. Also, I want to encourage you to learn about the political climate in our state, right? So recently, the state approved an immigration law that is going to affect many immigrants and members of the Latino community that is related to the tasks and expectations that members of the police departments and also the county sheriffs are expected to do in regards to informing ICE or immigration officers about the presence of an unlawful member. So that might affect the trust that we have in healthcare, but also they might delay the care that they need for them or for their family members. So I want you to be aware of that. It's very triggering for some of these families to see somebody with a uniform, with arms. They don't know the difference between security offers from police officer to a sheriff's office, from an ICE officer. So be aware that even coming to a healthcare system with a very large security department might be triggering for them, right? Finally, I wanted to provide some simple steps that you can use in your daily practice. And the first one is to avoid broad stereotypes. And it is important to understand what is the difference between a stereotype and a generalization. A generalization is an idea that I might have as a starting point, right? But it welcomes the curiosity. Say, I might have the idea that this person is Hispanic, so they might do this, instead of saying they are Hispanic and they do that, right? That is the stereotype. The stereotype is the end point. When I have a stereotype, that's the truth, and I believe that that is, and I'm not open to being curious about that community, right? So understanding the difference and being curious, as I mentioned, we are very different even within our own countries. So having questions, studying, attending webinars, reading papers, etc. Consider and understand the unique cultural differences and experiences that shape Hispanic, Latino, Latina individuals' views on healthcare and approaches to medicine. Ensure that when working with individuals with limited English proficiency, session documents and communication are in a language that the individual is comfortable with. So it is important that you use the resources that we have available. And Laura, I will give you, let me finish this and I will give you the floor. So now you know that we have translation services, that we have resources to be translated, that when they need to be translated. So, and probably you need a conversation with our interpreters on the difference between interpretation and translation. They are here to do interpretation, which is the live, verbal, oral change of the information, as opposed as written documents. Work to guide patients to preventative care resources, and we have available materials that can help them find resources in the community, even for uninsured patient. Educate yourself with baseline understanding of the cultures of your patients, where they come from and where is their culture. Speak up and advocate for your patients if you notice something that seems to be a major barrier as a result of cultural or language barriers. And finally, emphasize the importance of preventative care. So this is all I have for you today. We have 9 minutes for Q&A or for discussion, and I saw that Laura Contreras had a question or wanted to speak.
Hi, thank you, Liliana. And I wanted to point out that with all of this, I mean, great information that you gave us with cultural incorporation and awareness, you know, I work at Children's Hospital. I don't know if any of you know me or not. I'm an interpreter at Children's Hospital. And one of the things that, you know, I find when you were talking about the babies that are, you know, chubby and we like to see them like that, yes, that's very true. And sometimes I feel that the providers don't do enough to go into that explanation as to why it's not okay to feed them 4 ounces every 2 hours, 24 hours a day. And that's why the reason why they're spitting up or having all of this vomiting and whatnot, right? And other things like medications that were not prescribed to them that they're taking because it worked for my comadre or my, you know, my cousin or my aunt or whatever. And then we take that as, okay, I'm going to give them that, especially with the children, right? Because it's so detrimental. And the other thing that I would, you know, like to address to you guys, and especially your interpreters, is that when you're talking to them about, you know, when they're birthing and whatnot, you know, encourage them that if something comes up with the baby, go to Children's Hospital. Because a lot of times they come back to UT because that's where they were born. That, you know, like you said, it becomes like their primary care doctor, right? And then, you know, there's a lot of time wasted and there's a lot of back and forth about what needs to be done or not with the child. And by the time they get to us, they're way overwhelmed. They're, you know, I mean, I've had patients that have gone home after being told to come to the ER or to the hospital at Children's, gone home for hours before actually bringing the child to the hospital again. And you know, that creates a disservice because they don't understand that you need to go there now. You know, we saw your child here, but they need more care. And sometimes that doesn't get across.
Yeah. Thank you so much, Laura. And I want to open it for, I think we have about 5 minutes. Anybody has a question or a comment or would like to share with us? Well, I'm trying to see if we have anything in the chat. Thank you for all the comments about this presentation, and I hope you find it useful. And we will continue learning about different communities and groups in order to improve the health outcomes of this organization, this community. So thank you so much for attending, and we look forward to seeing you probably in November with more HERES sessions. Thank you so much. Have a great day. Bye-bye.